All right, well, hi everyone. Welcome to Medicine Grand Rounds today. Today we'll be kicking off with a presentation of the Dr. William Bremner Endowed Department of Medicine Mentorship Award. My name is Nisha Bansal. I'm a faculty member in the Division of Nephrology and the chair of the Mentorship Committee. It's really my honor and privilege to present the awards today. The first award is being awarded for excellence in mentorship of clinician, scholar, and full-time clinical faculty. And the recipient of this year's award is Dr. Stephanie Page. Dr. Page is a professor and the division head of metabolism, endocrinology, and nutrition. She's the Robert B. McMillan Professor of Medicine and Lipid Research and the co-director of the UW Medicine Diabetes Institute. I wanted to highlight some of the comments that were submitted on behalf of Dr. Page's nomination. People wrote, "She has helped me discover my passion. Dr. Page is my advocate. She's been flexible and ingenuous during the challenges of 2020. Dr. Page has instilled the motivation to keep moving ahead and not to settle for just good enough. She starts every meeting with, 'How are you? How is your family?' and recognizes that her mentees are whole people. And finally, Dr. Page exemplifies what I hope to be someday achieve in my life. Someone who is supportive of all she works with, kind but firm, someone who stands up for herself and her division, and someone who cares deeply for her family. She is a true example of how to succeed as a woman in science and medicine. She only builds up and never tears down." With that, I want to say congratulations, Dr. Page, and give you a moment to say a few words.
Thank you, Nisha, and those are very humbling comments. So takes me back a little bit. But I did want to just say a couple things. You know, mentoring and watching colleagues grow is really one of the real privileges of academic medicine. And I am just so very grateful to get to work with such talented people and for this recognition. You know, mentoring really is a team sport, and I'd like to first acknowledge my mentors who I have learned so much from, including Bill Bremner, who's here today and for whom this award is named, and Al Matsumoto, my other research mentor, who really taught me how to run a research program and mentor others, always emphasizing a team approach and a non-competitive approach to really continue to be goal-oriented, but also to foster success of every member of the team. And that's how we get to the ultimate research goals. I also want to acknowledge my administrative mentors, including Bill and Virginia Brody and Alan Chait and the other division heads in the Department of Medicine who have really taught me a lot about how to mentor and support fellows in a whole division, whatever position they may have, as well as junior faculty and my administrative colleagues, Mike Schwartz and Brad Anewalt, who continue to help to support clinical research and scholarly work in my division. And then mostly I want to thank the trainees whose career development I've been so privileged to be a part of, including many who are on the faculty now: Jing Chow, Katja Rubinow, Arthi Tharumalai, Tracy Tiley, Mara Roth, Sarah Maisioko, Catherine Din, and really all the junior faculty in my division and in other divisions who I've had the privilege to work with. The great Phil Collins, who I know we all quote every day, actually wrote, "In learning you will teach, and in teaching you will learn." And I really get the privilege of doing that every day. Thanks to all of you. So thank you, and I'm just so humble.
Wonderful, thank you, and congratulations again, Dr. Page. The next award is being given for excellence in mentoring physician scientists, and this year's recipient is Dr. Jonathan Himmelfarb. Dr. Himmelfarb is a professor in the Division of Nephrology and one of my personal mentors. He's also the Joseph Eschbach Endowed Chair in Kidney Research, the director of the Kidney Research Institute, the director of the Center for Dialysis Innovation, and the director of the Kidney Precision Medicine Project. I also want to highlight some of the many comments that were submitted on behalf of Dr. Himmelfarb's nomination. Some quotes included, "Dr. Himmelfarb always has an open door policy, despite how busy he is. His concern for my welfare is genuine, his advice is wise, and he's always willing to do what it takes to help. He invites us into his life. It is like joining his family. None of my successes would be possible without his sincere and substantial commitment. Dr. Himmelfarb is committed to supporting diversity, equity, and inclusion locally and nationally. I was not a kidney expert, but Jonathan convinced me that I wanted to become one. Jonathan believed in me even when I did not believe in myself. And finally, the most important lesson that I've learned from Dr. Himmelfarb is that the conduct of research is a privilege. It must always be centered on improving the life and health of patients. He has taught us by lived example that it is possible to operate with the highest ethical standards and scientific rigor while maintaining humanity and humor. Congratulations, Jonathan. I'd like to give you a chance to say a few words.
Well, thank you, Nisha, and thank you to the committee. This is an incredible honor for me. Especially, I really am moved by this, and especially as it's named after Bill Bremner. I came to UW in 2008 as the inaugural director of the Kidney Research Institute, and the support that I've had from day one, from Bill, from Ginny Brody, from Stuart Shanklin, the division chief, John Slattery, Conrad Lau, Sheila Lukart, they all really enabled us to get off the ground and realize the potential for what we wanted to do. It really is a privilege to be in this environment. It's been an incredible learning experience for myself, and I have really cherished the time at UW. Anybody who receives a mentoring award receives it because you have the privilege of working with great people. And it's been my privilege to work with a phenomenal group of talented investigators. It really is team science, and try to lift all the boats around us. And I'll just comment that I'm especially proud that 4 individuals during this time, Brian Kestenbaum, Ian DeBoer, Nisha herself, and this year Bino Friedman, all of whom I've had the privilege of working with, were Fialco awardees during this time. So I'm really proud of their accomplishments and all the other people, the great people that I get to work with. So this is really very, very meaningful for me, and I really appreciate it. Thank you very much. I'll turn it back to you, Nisha.
Dr. Bremner is going to say a few words now. Thank you.
Thanks very much. It's really a great pleasure to be with you today and honoring our 2 outstanding mentorship awardees. We have heard a bit from Nisha about some of their very impressive accomplishments and accolades. I know them both very well and heartily agree with all the compliments about them, and feel the selection committee has made excellent choices. I want to thank Nisha and her committee on behalf of all of us for their excellent work. They needed to choose from among many, many superb mentors in our department. I would also like to recognize Helen Shu, the founding chair of the mentorship committee, Dr. Shu, and Dr. Conrad Lyles, our associate department chair, for their work in implementing the committee and these awards. And certainly I'm grateful to the Department of Medicine leadership, who decided approximately 2.5 years ago to add my name to the title of these awards. I also wish to acknowledge the work of many, led initially by Dr. Emily Wong, a former faculty member and director of the Women's Clinic at Roosevelt, and associate chair, in securing the resources necessary to endow these awards, thereby providing a financial honorarium for the awardees. I also wish to thank our present department chair, Dr. Young, for her staunch support of Grand Rounds and the various awards presented here, and for her regular attendance. Conferences such as Grand Rounds help foster communication and community spirit. In normal circumstances, they foster direct person-to-person contacts, a smile, some words, a handshake, perhaps an occasional hug. While some of these things are not now possible during the pandemic, these Zoom conferences have become a useful and interesting substitute. They may even have a couple of advantages, such as allowing easier interactions from a distance. And certainly mutually supportive interactions are even more important in this setting of external stresses that we're all enduring, such as events in Washington, D.C. in recent weeks, as well as our need for significant improvements in racial, cultural, and gender advancements. In closing, a comment or two about mentoring specifically. Mentoring has been one of the most useful and pleasant aspects of my own career, and I know that this is true of many people. Being both a mentee and a mentor have been uniquely valuable. In some ways, one continues to be a mentee throughout one's career. To learn from and teach some of the smartest and most capable people in the world is a great privilege. We are all very lucky to be in such an environment. So thank you very much for the opportunity to give these brief comments. Now I wish to turn it over to Dr. Johnny Hermosdy, who will introduce Dr. Helen Shu, whom I know we are all anxious to hear speak. Thanks very much.
Thank you, Dr. Bremner, and thank you to our deserved awardees for your mentorship and your leadership. It is my great pleasure to introduce to all of you our Grand Round speaker, Dr. Helen Shu, Associate Professor of Allergy and Infectious Diseases. Her research is focused on preventative interventions against influenza, RSV, SARS-CoV-2, and other emerging respiratory viruses. Dr. Chu conducts clinical translational research on a large-scale, community-based studies of respiratory viruses with a focus on vaccines, antivirals, and diagnostics. She is a multiple principal investigator of the Seattle flu study, which first identified COVID-19 community transmission in the United States. She's a co-investigator on the University of Washington Vaccine Trials and Evaluation Unit and site principal investigator for the ACT-1 trial, which evaluated remdesivir for the treatment of COVID-19. During the spring of 2020, her lab enrolled a prospective observational cohort of 350 COVID-19 inpatients and outpatients to further study and better understand the immune response over time. More could be said about her accolades and accomplishments, but that would further delay an exciting Grand Rounds talk that I know we're all anxious to get started. So I'm gonna skip ahead here and turn it over to Dr. Chu. Please feel free to leave questions in the chat, and we will have some time at the end for a brief Q&A. And Dr. Chu, I'll be moderating that chat for you as well. Feel free to share your screen.
Great, thank you so much. And first of all, congratulations to Dr. Himmelfarb and Dr. Page for your honor. I feel like mentorship is really the thing that I aspire to do well the most. So I'm so delighted to see you receive these deserving awards. So I'm going to talk today about pandemics and how to prepare for a pandemic, and really go over the history of the work that the Seattle flu study has done over the last 2.5 years now, as we've been thinking about how to ready the United States for a pandemic and how we've pivoted those responses to coronavirus as it arrived in January of last year. So these are my disclosures. And I first wanted to acknowledge that the work that I'll be presenting is really the work of over 250 individuals, that this is not work that is done by any one person. It requires all of us to all work together, and has really been an experience in team science, which I'm grateful to be a part of. I know that many people here are on the call, and I'm happy to have you correct things as things come up in case I get some things wrong. So, and these are the members of my lab who've really done so much of the on the ground work for all of the studies that I'll be presenting. So this is the outline of my talk. First of all, I'd like to go over influenza as the source of past and future pandemics. Then how we developed the Seattle flu study as a pandemic surveillance platform, how we started the process of community-based surveillance, and some of the early work we did on home diagnostics and treatment for influenza. And then in January of last year, how we shifted quickly in response to COVID-19, and some of the work that we've done in the homeless shelters in Seattle. And then more recently, in the last 3 months, some of the work that we've been doing on the University of Washington campus as part of the Husky coronavirus testing program. And finally, I'd like to end with some future directions and my thoughts on what is needed to pull us out of where we are now. So just some very brief background on flu and why we chose to focus on flu. So flu is an RNA virus. It's segmented. It has two major surface proteins, hemagglutinin and neuraminidase. Because it's segmented, it reassorts quickly. And epidemics occur when there's antigenic drift or small changes in the genome that are associated with seasonal epidemics. Pandemics result from major swaps in the hemagglutinin or the neuraminidase gene, which lead to larger scale outbreaks globally. For example, a switch from H3N2 to H5N2. Like many emerging pathogens, flu has a zoonotic source. The general direction of transmission is birds to swine and then over to humans. And then as for many other emerging pathogens, ongoing surveillance is really necessary to identify novel pathogens. So this is the infamous W-shaped curve from 1918, where we saw more cases of death due to influenza, both in the very young and the very old, and also in this age group from the 20s to the 30s. And when we think about pandemics then versus pandemics now, back in 1918, what happened was that the world population was about 2 billion, that most transportation was via troop ships or railroad, and it took about 4 months for a virus to circulate the globe. The things that were used for prevention included masks and disinfectants, which is also what we had. And then bed rest and aspirin was really what was used for treatment. And it was estimated that 2% of the population died due to 1918 flu, both in 1918 and then in the subsequent winter. In 2021, our world population has quadrupled to 8 billion. The primary mode of transportation is by airplane, and it takes about 2 days for the virus to circulate the globe. We now have vaccines, three vaccines that are now have emergency use authorization, and also many antivirals that have been rapidly developed for use for treatment of SARS-CoV. And it's estimated as of a few days ago that there are 1.9 million who have died from SARS-CoV, and then potentially many more in the next several months. So we started the Seattle flu study about 2.5 years ago in 2018. At the time, it had been 100 years since 1918 flu. We felt like we were in a position where another pandemic was inevitable. Current surveillance strategies in the United States were not really well designed to detect new pathogens. And therefore, the objective of the flu study was to develop a pandemic surveillance platform that could be used to identify new pathogens, and then to develop strategies for rapid containment of spread for what we thought it would be the months to years it would take for a vaccine to be developed. So at the time, and what is happening now as well, is that the current surveillance strategies that are in place for influenza and for respiratory viruses rely heavily on people who are coming in for care. They rely on reports from clinics and hospitals of flu positive samples from people who are coming in with respiratory illness, and then rely on reports of influenza-like illness using syndromic surveillance from the Centers for Disease Control. But the key missing piece of that is that it really doesn't capture individuals who don't seek care. And we hypothesized that it was these individuals, the ones who never came in, who may contribute to spread in the community, who could introduce novel strains, and then may provide an earlier signal of flu activity than hospitalized patients. So our hypothesis was, can we capture individuals with flu in the community who are not care seeking? The other piece of this was the idea of using home-based sample collection and home-based diagnostics. At the time, 2.5 years ago, there were many influenza diagnostic tests that were in development for use at home, and they relied on self or parent collection of a nasal swab, and then either a molecular and antigen-based test that was done at home, and that would then subsequently link to care and receipt of an antiviral. None of them are licensed for use at the time, but we partnered with one of the companies, Illume, to study this. At the time, there were, I think, 3 companies that were working on home diagnostics for influenza. It was Lucira, Lumira, and Illume, and we talked to all 3, and at the time, Illume was the furthest along. And as of January 2021, there have now been 2 EUAs issued for home diagnosis for SARS-CoV-2, and they were issued to 2 of the companies that we spoke to. And the data I'll be presenting will actually uses the same platform for diagnostics as is used now for SARS-CoV. So as part of this study, we really wanted to answer, are individuals able to self-collect a swab? And what do they do with a virus positive result? Do they take action on it or do they not? So we had a multi-pronged strategy. The first was to expand testing to the community. We wanted to look in college campuses, in child cares, in schools, workplaces, homeless shelters, and transit stations, places where people would be walking around with respiratory symptoms may not necessarily come in for care. We really focused on building a high throughput lab that could identify multiple viruses at the same time and have the capacity to rapidly design a new test for novel pathogens, and then to do whole genome sequencing to look for emergence of new strains and then to map chains of transmission. We wanted to establish the ability to merge clinical and laboratory data very quickly so that we could identify risk populations and understand the geospatial spread of pathogens. And then finally, we wanted to figure out new ways to diagnose and to treat respiratory viral pathogens at home, to limit exposure of sick individuals to others in the healthcare setting. And so this is what our workflow looked like. Some of you may have seen this. We had these kiosks set up all over the city over the course of the last 2 years before the pandemic. And so what would happen would be somebody would come up to our kiosks. We would screen them for eligibility. They had to have at least 2 of the following symptoms in the past week: feeling feverish, having a cough or sore throat, runny or stuffy nose, fatigue or tiredness, increased trouble breathing, or any of the more non-specific symptoms on the right. If they were eligible, they went through an informed consent process. They completed an app-based questionnaire on the tablet, and then we took a swab from them, and then they got a gift card for participation. What we found was that less than 1% of individuals enrolled based on the symptoms on the right. The vast majority were the symptoms on the left, which were more traditional respiratory virus symptoms. So we had these community enrollments from all of these public sites, from homeless shelters, from child cares, from the international arrival zone at the airport, from multiple workplaces throughout the city, including Costco, college campus, the University of Washington, tourist attractions like under the Space Needle. We were also positioned in waiting rooms and in urgent cares for family members who'd come with someone who was sick, for people who weren't necessarily there for a respiratory illness. And then simultaneous to this, we also collected samples from the hospital. And these were samples that were collected from providers who collected it at clinician discretion. So essentially those who came in with a respiratory illness and had a swab collected at any of the 3 adult or 1 pediatric hospital. We would pull those samples, we would test them for the multiple pathogens on our panel, and then we would extract the clinical and the socio-demographic data from the electronic medical record. There were multiple community partners that were involved in the work that we did, and it was really due to the willingness of these community groups to work with us that we were able to do this work. And I think one of the things that was very, very clear was that once the pandemic hit and we were in a position where we still needed to do surveillance in these critical sites, that having these partnerships in place early on from our flu studies was really essential to be able to continue the work. That there was a real fear of continued surveillance in the community during the pandemic, but the fact that we were already at these places, we had been doing the work there for 1.5 years at the time, and that we were trusted members of the community who were working with them, allowed us to continue a lot of the surveillance work that helped us find the early cases. So one other component of the Seattle flu study was really the idea of being able to collect a swab at home without supervision. And this was work that was led by Ashley Kim, who is a research scientist in our group. So people would go to our website, seattleflu.org, and then they would enroll in something called Swab and Send. They would fill out an illness survey, and then in about 2 hours, a swab kit would arrive at their house. We would use a rapid courier service. They would follow the instructions, collect a swab, package it back up and bring it back and send it back to us, also using a rapid courier service. And then we would turn around the results in about 24 to 48 hours. They would then enter the barcode on the website, and then their results would be given to them. So this is a mock-up of our website. It was designed for us by a marketing firm called Formative, and really allowed us to continue remote enrollment, especially during the pandemic when a lot of the on-site enrollment had to shut down. And this is what the what we call a quick start guide looks like. So this is how people were able to know how to collect a swab on their own. This was translated into 9 languages. It would go to people's homes. They would follow the instructions, self-collect a swab, and then send it back to us. And then once it got back to Leah Starita's lab, she would then put it through a multiplex RT-PCR panel. And we decided on these initial 26 pathogens for the panel based on the potential for being causally associated with respiratory illness. And then we added the influenza A primer to capture novel flus that could potentially be causes of a pandemic. We did not include a MERS or a SARS coronavirus, but we had all the human coronaviruses on here. The samples that were then identified as flu positive would then move on to whole genome sequencing using a hybrid capture approach. And then that would allow us to understand the movement of different strains throughout the city. And so these were results from our first year. So here you can see that we had 5,477 people enrolled from the community, and 20% of them had evidence of influenza on PCR. Simultaneously, we collected over 12,000 samples from the hospital, and we found that the same proportion had influenza from those samples. One of the things that was striking to me was that 39% of those in the community had influenza-like illness. So normal, healthy people walking around with influenza-like illness. And the predictors of greater flu positivity were being younger or having been enrolled in a waiting room at a clinic. And one of the things that we really wanted to do was to try to capture people early in their illness, because for flu, you want to treat within the first 72 hours for greatest efficacy. So we wanted to see how many people could we diagnose early. And we found that we weren't very successful at that. We were only able to enroll 1/5 within 48 hours of symptom onset and 37% within 72 hours. And of the adults who enrolled, only 21% reported seeking care for their illness. So 80% never sought care for their respiratory illness. And then here is a visual representation of the different flu strains that we saw that first year. We saw an early peak of H1N1, followed by a later peak of H3N2, and not very much flu B. These are some of the results from the whole genome sequencing that was performed as visualized on NextStrain, which is a website developed by Trevor Bedford, who's one of the PIs in our group. So here, what you can see on the right or on the left is a phylogenetic tree showing all of the strains that were sequenced worldwide at that time point, which was as of April of 2019 for that season. And the first thing to note is that the red dots, which represents the samples that we sequenced in Seattle, were a large proportion of the overall worldwide sequences, that we were responsible really for a large proportion of the samples that were sequenced around the world. And it also sort of emphasizes the point that there was not a lot of sequencing happening nationally or globally at the time, and that the effort that we led to sequence several thousand genomes was really accounted for much of what was available. And I think that's something actually that you can see now as you think about the emergence of 501Y and the 484K, that the lack of sequencing globally is part of the reason why we're not able to know how quickly those strains are spreading worldwide. So what you can see here is that in the red dots each represent one strain that was sequenced. The one thing to first point out is that there was a diversity of sequences that we observed. We saw a lot of different strains that came into the city, and that some picked up and caused little clusters, and then some extinguished very rapidly. And then here, what you can see is the entry of the different strains over time. So what happened was that in January, that first sample was a strain that was very related to a sample that was to strains that were circulating in Europe at the time. And then there were multiple strains that then entered the city into different parts of the city, and some of them picked up and then some of them extinguished. So emphasizing that there were multiple diverse strains of influenza circulating at the time. And so this was sort of the end of our first year. We felt like it was, pretty successful. We were able to demonstrate that we could collect samples in the community. We had developed a way to be able to do remote collection in people's homes. And we were heading into year 2 of our Seattle flu study, and we had a couple of new studies that we were planning on home diagnostics. However, it was at the time that in January of 2020 that we became aware of coronavirus circulating in China and potentially having traveled to the United States. So many of you, I'm sure, already know the details of this story, but essentially as part of Seattle flu study, we had been collecting these samples from the community for the past year and a half, and we were in the position of being able to very rapidly go back to our biobank and to start testing for SARS-CoV-2. It took many, many weeks of discussion with FDA and CDC and Department of Health before we were at the point where we were able to go forward. We did go ahead and start testing, and essentially as soon as we started testing, we found a case. And so that sample that was positive was then moved on to whole genome sequencing. And within the next 1 to 2 days, in Debbie Nickerson and Jay Shindori's lab, they were able to quickly ascertain that sequence was related to the initial sample from the first patient in January, indicative of community spread in the United States that had been ongoing for several weeks. So we then went back and tested all of the samples that we collected from January 1st onward, really to understand when SARS-CoV-2 entered the Seattle region. And we found that the first sample was on February 24th, and that there was really no evidence by molecular testing of the biobank of samples that there was any earlier entry. We've also collected a lot of serum samples and tested those by ELISA, and also found no evidence of immunity until March. So these were the results from that first group of individuals. So we enrolled 2,353 individuals in Swab and Send. 25 or 1.1% had COVID-19 or SARS-CoV-2 detected. And really all of it was after that February 24th case. And only a small proportion, 1/3, reported seeking care for their illness. And that the median duration of symptoms before swab collection was 4 days, indicating that people were probably symptomatic and spreading before they had a diagnosis made. We've then taken the Swab and Send platform and in collaboration with Public Health Seattle, King County, and with CDC have converted it to a program called SCAN, which is Seattle Coronavirus Assessment Network. And as part of that, we've now tested 33,000 individuals over the course of the last 6 or 7 months. And found a positivity rate, that's 2.2% are positive, and that only 8% of those who are positive reported seeking care for their illness. So a pretty consistent number in that the people who have SARS-CoV in the community who are swabbing at home and then sending the samples to us, very few of them are actually being captured by traditional care-seeking platforms. This is a phylogenetic tree of those initial SARS-CoV-2 cases. What you can see here is evidence of introduction and then community spread of SARS-CoV early in the pandemic here in Seattle. So one of the main questions that comes up when we think about these home collected swabs is how do you interpret them? How comparable are they to the gold standard, which is a provider collected nasopharyngeal swab? And this was work that was led by Denise McCulloch, who is a fellow in our lab. And she collected samples from individuals who came in for testing at the drive-through clinics and provided home test kits to these individuals. And then we compared performance of a home unsupervised swab collection to the clinician collected nasopharyngeal swab. We found that that in comparison to the gold standard, a home self-collected swab was 80% sensitive and 98% specific. And that when we restricted it to samples with a CT value of less than 32, so higher viral loads, that the sensitivity of home swabs was 95%. And that these swabs the results from these swabs were actually very highly concordant. And I think what this did was it reassured us that not only could people collect the swab on their own, but for samples where, with a CT value of 32 and below, then those were very sensitive in detecting SARS-CoV-2. So one of the other things we wanted to do was to understand whether or not you could diagnose someone at home, connect them to a provider, and then treat them at home. So we did this for influenza in the context of a household study. We enrolled families with young children who are more likely to have flu. We enrolled them virtually. All of the study procedures were done virtually. We wanted to be able to create something that could be done that was completely contactless. So we enrolled them virtually. They completed their consent forms and their enrollment questionnaires via RedCap. They either had text message or email for weekly surveillance for respiratory illness. And then we provided them with 2 swabs, one for the swab and send to send back to us in the lab. And then we worked with Illume to provide them a home flu test. And so when people had symptoms, they were asked to collect 1 swab for the home flu test and the 1 swab for confirmation by molecular testing in our lab. And when they tested positive on the home flu test, they were connected to a telehealth provider who then prescribed baloxavir, which is a 1-dose antiviral that we used for this study. And that was sent to their house. And what we found in this study, and these are preliminary results, was that people did pretty well. So on the left is a graphic of what the Illume test looks like. You can see here that there's a little, basically it's a Copan swab that's been cut off and attached to the applicator. People use that, they swab their nose, then they put it in a solution and then they drop it into this piece here. It's a lateral flow assay that runs through, and then the intensity and then it produces a fluorescence signal, and the intensity of that fluorescence is then transmitted by Bluetooth to your smartphone. And then based on the intensity, then it has a readout of positive or negative, which is transmitted to you as well as to your provider. So at the time they were developing this for flu, and we thought this seemed like an easy to use platform. We wanted to try it out and see if people could do it. And so we found that people could, that 185 households were enrolled in this particular sub-study. We found 38 cases of lab-confirmed flu from 30 households, and 164 home flu tests were used over the surveillance period. Sensitivity wasn't bad, it was 69%, and specificity was 96%. So, and then based on the positive result from the home flu test, people were then sent an antiviral. And I think one of the key things is that we were able to get the antivirals to these individuals very, very quickly, that we were able to provide antivirals to 16 sick participants. 81% of this occurred within 3 hours of prescription, and 31% of antivirals occurred within 24 hours of symptom onset. And I think that was a real metric for us. How quickly can we get it to someone after their symptoms started? Not necessarily when they tested or when they went through all the procedures and had the prescription, but after their symptoms started. And we were pretty successful with that. We used a rapid delivery service. We worked with the University of Washington Investigational Drug Service. And then we were able to do this. So theoretically, this provides a proof of concept for home-based diagnosis, referral to care, and treatment, rapid treatment for influenza in the community. So we also went ahead in these individuals, in these households, and had them self-collect swabs for testing in our laboratory, and we had that 26-plex assay. So we collected 678 swabs among over 1,000 unique participants. 237 of them, or about 1/3, tested positive for at least 1 non-flu virus. And using this household study, we were actually able to find early cases of SARS-CoV in 3 households before April 1st of 2020, before really we knew that there was a lot of SARS-CoV circulating in the United States. And those initial cases were all in adults. We have since modified the study to allow us to do follow-up testing of both symptomatic and asymptomatic individuals once a positive case is identified. And these 2 studies were led by Annie Emanuels and Jessica Hyman in my lab. So here, what you can see is that there were a lot of viruses in these households back then when there were still viruses circulating. So we found a lot of RSV, a lot of parainfluenza, a lot of rhinovirus, and a lot of human coronavirus. And then we found those 4 cases of SARS-CoV-2. So home-based studies are a good way to really capture secondary attack rates of respiratory viruses in households, which are very high risk, and then potentially also serve as a good place for introduction of interventions early to prevent further spread. And then what we also found was that when we compared these two ways of symptom tracking for respiratory illness, the people in our study were, first of all, very, very compliant. That this red line at the top indicates how many people responded to what proportion of people responded to their symptom alerts every week. And you can see that it hovered around 95, 97% the whole time. So people were very much engaged and able to do weekly text message or email response. And critically, one of the things that we found was that text messaging was much better, that we were able to achieve a faster response time with text messaging than with email, which is really critical when you're thinking about capturing people with symptoms early enough for an intervention. You want to find the fastest way to find out about their symptoms. And since then, we've really moved on to use text message primarily for most of our studies, because it does seem to be the way that people want to respond. So what are the lessons that we learned from our study? We learned that having biospecimen repositories linked with clinical data are essential for real-time identification of novel pathogens. Community-based studies provide an opportunity to identify pathogens early and take steps to prevent further transmission, and that these contactless studies to test, diagnose, and treat for respiratory viruses could provide a strategy to limit exposure to ill individuals in times of a pandemic, although early identification is still challenging. So then after SARS-CoV-2 arrived, we really had to pivot a lot of our work because we weren't allowed to continue on-site collection at a lot of our sites because for safety reasons. One of the places where we did continue to do work though was the homeless shelters. We had initially started working in homeless shelters in collaboration with Nancy Sugg and Healthcare for the Homeless, really because when you think about a pandemic, or when we thought about it 3 years ago and thought about what you would ask people to do if there was a pandemic, you ask them to shelter in place. You ask them to stay home and not to socialize with other people or be around other people, but that was not possible in homeless shelters. So what we wanted to do was, first of all, to understand the burden of disease due to respiratory viruses in homeless shelters and to develop a way to rapidly diagnose and then treat respiratory illness in the shelters. So we initially started a randomized clinical trial of influenza testing and treatment, which is actually still ongoing. But in the middle of all of that, coronavirus happened. And so we had to rapidly pivot to testing and identification of cases of coronavirus. So this is work that's led by Julia Rogers, who is a PhD Epi student in my lab. And what she did was, which was quite a lift, she worked at over 14 shelters in the Seattle area, the Mary's Place Shelters, Campus Housing Alliance, DESC, St. Martin's. I think that's it. And then Roots. And we were at all of these shelters and we enrolled people with and without respiratory illness. We were on site 6 days a week. And people could either enroll at any point in time, really, on any of those 6 days. But once there was an identified positive, we went into something called surge testing, which is really massive testing of every single person at the site and repeated intensive testing until there were no longer any positive cases. When someone was identified as positive, we removed them from the shelter to isolation and quarantine facilities managed by public health, and then they return according to public health regulations. So we were in 19 shelters since March, looking for evidence of SARS-CoV-2. There are 14 adult shelters, 4 family shelters, and 1 youth shelter with a total capacity of 2,000 people a night. We conducted 8,000 surveillance tests. 85% were routine surveillance, 15% were these surge testing events once there was a positive, and 70% were in the residents rather than the staff. We averaged 1 to 2 surge testing events per week, which was once there was an identified positive, we went out with a larger group of staff and tested more intensively. And there were, doing this study was very challenging during the pandemic because what happens at these sites is that they often move. So they'll be at one place and then they need to what's called decongest. So they split up the shelter and they move to 2 separate sites. And this kept on happening during the course of, and continues to happen actually over the course of the last 10 months. And so what our staff did was essentially just follow the clients and go wherever they were and then continue to do the testing. And this is an epi curve showing the number of cases that we found. And really what we wanted to know was whether or not there was evidence of introduction by a certain type of individual, or was it a resident-driven outbreak, or were they staff-driven outbreaks? And what you can see here is that we really did not see that. We found that really once cases started popping up, it popped up in both the residents and the staff simultaneously. In both this outbreak in the family shelter and then this later outbreak in the adult shelter. And this is what we saw pretty consistently throughout our study. So when you think about a policy to vaccinate in homeless shelters nationwide, one of the things I think that's really important to consider is that it's not clear who's introducing. And so you shouldn't focus on, say, just vaccinating the staff, but that really the clients and the staff need to be simultaneously vaccinated to prevent ongoing spread of SARS-CoV within the shelter. This is a bed map of one of the shelters. The red individuals are those who are enrolled in the first surge testing event. And then the blue ones or the yellow ones were enrolled in the second testing event. And we are starting to map out the spread of SARS-CoV in these shelters. We also have environmental sampling that we've performed. And really the goal here is to also incorporate other characteristics like frequency of cleaning, how closely the beds are spaced, what is the sort of arrangement within the shelters? Are they individual sleeping areas, or are they sort of these communal spaces? And see if we can identify factors that are protective against spread of transmission in these types of closed living facilities. And then one final thing that we did within our homeless shelters, which is an ongoing project led by Amanda Casto, who's a junior faculty member in our group, is really to perform whole genome sequencing of the samples that we collected from the homeless shelters to get a better understanding of whether or not there is within shelter spread, or whether the cases are really just indicative of what is circulating in the community at the time. And I think one of the things that we learned from that sequencing, the early sequencing, is that at the beginning of the pandemic here in Seattle, there was not a lot of diversity in the strains that were circulating in the community. So that even though we saw a cluster of the same strains in a shelter, they were also very, very similar to those that were in the community at the same time. And there was really only over time in the later months of the pandemic that we're starting to be able to tease out identification of these clusters of outbreaks. And here you can see two of them that we've sequenced so far. This early data still, we have a couple of recent large outbreaks that Amanda is working on. And we're hoping that all of this data, along with the geospatial data, will give us a better understanding of clustering within the shelters versus clustering within those certain geographic regions in Seattle as a whole. So from the shelter study, what we found was a relatively low burden of SARS-CoV-2 compared to other congregate settings, such as prisons or skilled nursing facilities. We think this actually has a lot to do with the fact that there is just an incredible amount of testing. And once the case is identified, they're swiftly isolated, and then close contacts are quarantined. And that really worked to prevent ongoing spread within the shelters. There is no clear pattern of who was introducing, whether or not it was residents or staff. And so a vaccination strategy should really focus on simultaneous vaccination of both groups. And then we are finding some genetic evidence of transmission within the shelters, but I think more sequencing data is really needed to be able to know for sure. And I think that's actually holds for a lot of the other studies that we're doing, is that early in the pandemic, you would not be able to tell. But as things have progressed and there has been introduction of multiple different clades into the city, we're now able to paint a picture of clusters within certain communities. I am seeing how I'm doing on time. So, do I have time to? Okay, I think I do. Okay, so in the last part of my talk, I wanted to go over some of the work that we've been doing in the college campus. So this is part of the Husky coronavirus testing program. This is the work that we've done in collaboration with Jeff Gottlieb and with Katya Harb at Environmental Health and Safety at the University of Washington to really understand and control outbreaks within the UW community. So as part of this study, we enrolled all individuals who are at the University of Washington. Many of you are probably enrolled in this study. And what we have them do is enroll to have a baseline test collected and then to do daily symptom attestations. And then when they test positive either to an exposure or to symptoms, then we offer them a test either through swab and send or through a kiosk. And then we test these in our lab and return results very rapidly. So this was our initial study design, and this was really developed and led by Anna Weil and Sarah Solberg, who work on this project with us. And really, we wanted to stratify individuals at the university into 3 tiers based on their living situation, mostly, and then whether or not they came to campus. And we thought that tier 1, who are these students who live in dorms or Greek housing or who live off campus in large groups, were probably the highest risk to acquire SARS-CoV. And so we wanted to heavily focus on sampling of this group. And our planned enrollment in September was 15 to 20,000. And so we had a plan that we developed, and this was our plan. And the idea was for us to do a baseline test, then to do these attestations, and then to do regular surveillance testing in all of these groups, really to understand what the baseline prevalence was in each of these tiers to see if people were being classified into the right risk categories. And then to do surge testing in the event of an outbreak. However, what happened was that we found that as soon as we started the study in September, on September 24th, I think it was the next day, that there was a massive outbreak. And so we very rapidly had to switch from baseline testing straight to surge testing. And we had no opportunity to ever start any surveillance testing in the community. So despite all the plans that we had to do it a certain way, we weren't able to actually do that because we had a Greek outbreak to deal with. So these are some results from that fall quarter from the work that we did. So we enrolled almost 17,000 people over the course of 3 months. We actually broke red cap and the whole system went crashing down for a while because we overwhelmed the server. And then we had an overall positivity rate of 0.8%. Our turnaround time was actually quite fast. It was 15 to 23 hours from swab collection to results. And we found that there were certain risk groups that were higher risk for positivity, including those who had a close contact with a known COVID case, and then those who had symptoms. We found that most of the positives were within this 18 to 49 group, but that really it was concentrated within the 18 to 22s. There's slightly more women, and that importantly, almost 80% of people who were positive in our study had no symptoms at the time of testing. And I think that was really, really surprising to us. We did not expect that number to be so high. This is an epi curve showing the results from Husky testing. The red represents Greek positives and the blue represents non-Greek positives. And you can see essentially we started our study on September 24th, and by 2 days later, we had an outbreak. And so we rapidly pivoted to testing of all members of the Greek community every 72 hours. And this was really the suggestion of EH&S. They were concerned about just one-time testing, and that was actually a really important thing that they recommended, because as I'll show you in the next couple of slides, we found some things that I think are useful as other campuses think about how to test. So these are individuals. Each box represents one individual. And these are repeated testing episodes in the individuals. And on the x-axis is time, and then the dots each represent a result. So the green represents negative, the blue represents inconclusive, and the red represents a positive. And what you can see here as you sort of dial in on each of these individuals is that we find that in the setting of this Greek outbreak, that many people were testing negative multiple times before they had their first positive. And that if they had just been tested once or even twice or 3 times, we probably would not have picked it up. And that it was really the repeated testing, repeated high frequency testing that allowed us to find the positives and to achieve containment and stop the spread of the virus within the Greek community and then the larger UW community. One of the other things that we looked at was viral load. Does viral load, which is a marker of infectivity, differ between those with and without symptoms? And we found that in our study, we did not see a difference. It could be that many of these asymptomatics are pre-symptomatic, and we don't know that yet. We have to go back and get their symptom data in follow-up questionnaires. But at the time of testing, they were not exhibiting any symptoms, and their viral loads were really no different from those with symptoms. And then these are the early genomic results that has been compiled by Amanda. And here what you can see is that these are samples that are collected. The blue represents King County. The green represents the UW Greek system. This was that early outbreak in the summer, if you remember. And then this was that September outbreak where there's a cluster of cases within the Greek community. The yellow represents non-Greek. And so one of the questions that we have, and an analysis that Amanda and Trevor are leading, is there spillover? So is that, once you have an outbreak within a small, fairly closed community on the UW campus, does that then lead to spillover into the general Seattle community? And we're starting to see early data that there may be evidence of spillover, that these were the Greek cases, and that these are cases that are in the general community that may be downstream of these initial Greek cases. This is very, very early data, so it's hard to sort of make any conclusions. We have another batch of samples coming off of the sequencer, I think today, and we'll be able to have more information about what's happened in October, November, December. But I think what we're trying to do is to really better understand whether or not UW is an island or whether there's actually spillover, and that has implications for control and risk and what the activities on a campus mean for the general population. So these are our lessons learned. Our highest positivity rates are among those with known exposure to COVID positives. Repeated testing is essential to capture new infections. The majority of positives are asymptomatic at the time of testing. And sequence cases really clustered close together, indicative of an explosive growth of the Greek outbreak after an introduction early to mid-September. And that the non-Greek cases did not seem to cluster with the Greek cases. And it remains to be determined whether or not then that leads to spillover into the general population. So I wanted to end with this, which is a figure of what is happening in Seattle over the course of the last 3 years. And what you can see is that we see circulation of lots and lots of respiratory viruses, but that once coronavirus hit, that we really saw obliteration of flu, of RSV, of all of the viruses except for rhinovirus and SARS-CoV. So what we'd like to do over time is really to monitor what happens as vaccines are introduced and life returns to normal, and see what happens to circulation of everything else. Okay, so our future directions, we're working with Seattle Public Schools and Snohomish Public Schools to help them develop a testing platform. Working with Apple to look at physiologic predictors of illness, looking at transmission dynamics of COVID within families, and continuing our work in the homeless shelters. And we're hoping to work on population level VE with SARS-CoV-2 vaccine introduction. And that's it.
Thank you, Dr. Chu. Wow, what an incredible story, and just an awesome presentation. Seeing lots and lots of agreement among folks in the chat. There are a couple questions. If you have time, we can start off with one that was asked by Dr. Cho that seems like you were sort of starting to answer there in that last slide. This year, seasonal flu is virtually non-existent in the clinic and hospital. And so how will we know, or is there any way to predict sort of what that means for future flu seasons?
Yeah, I think we'll probably, my prediction is that we are not going to see much flu at all until things reopen. So I don't think we're going to have a flu season. Unless vaccines get rolled out much quicker than they're currently getting rolled out, I just don't see how it's going to happen.
And will that change some of the characteristics of then the flu season that might emerge next year?
I think we're not going to have, my prediction is that we're not going to have much of a flu season for the next couple of years, because I think that a lot of the non-pharmaceutical interventions that we've, taken as a society, the masking and the social distancing and like the limiting of gatherings, those will not go away even when we have a vaccine. And so, the R naught of flu is just so much lower than SARS-CoV that I think that the measures that you take for SARS-CoV, even the limited measures, will prevent circulation of the other viruses.
Got it. Yeah. Another question was about the widely reported fact that the UW-IRB had halted ongoing examination of the flu study samples for SARS-CoV-2. Could you speak a little bit to that?
Yeah. So it's not the IRB that stopped us. It was the FDA. So the FDA asked us to stop. And then what happened with the IRB? I think, so what happened was that we had been talking with CDC and FDA about this, and they had said to go forward and go ahead and start testing, that it was okay. So it was not as sensationalist as the New York Times reported, but that really sort of the issue was that we returned that result, that we had the results and we returned it to the participant, and that particular sample was a residual sample, that very first positive. And so we were not legally authorized to return that result. And we felt as a group, and not just me, but like our core group of investigators, that it was ethically not the right thing to not return that result. So we went ahead and did that. And so then we had to shut down, but it was not driven by UW-IRB. In fact, they've been very, very amazing to deal with this entire time. They've been really, really great. It was really sort of this perception by FDA and CDC that we were going against what we were permitted to do as a research study, and we knew that. We went in intentionally knowing that we were going to violate that protocol by returning that result. But we were sort of in a situation at the time where we didn't know if he was going to be sick, and we felt like we had to let them know. So.
Wow, really drawing into play the ethics versus the regulation there, when the ethics floor is a bit higher than what the regulatory ceiling allows. Really, again, just an incredible story. A couple more questions have come in. Specific populations that didn't seem to be suppressed amongst the stay-at-home order, specifically mentioned is the Hispanic population here locally. Any thoughts about that now that we've had some understanding of clustering and spread that way?
Essential workers. I think it's really that the essential workers, the high risk workers, did not have the advantage of being able to work from home and to do all the things that needed to happen to be able to stop acquiring. That it is disproportionately the essential worker population.
Yeah, and I think that's what we've postulated. If viral shedding is maximal early in COVID, why then was it so imperative to do multiple serial tests during these outbreaks?
Yeah, so people were incubating. They were in the incubation period because what was happening at least in the Greek houses, it looks like it was explosively spreading, but that everyone had their 5-day incubation. So we were testing during these incubation periods, and we caught them as soon as they became positive. And that was a lesson that we really learned from that. That was really, really important to be to show that we could capture that first positive, because that first positive was often a very, very high viral load.
And a sobering thought that symptoms are in no way predictive of shedding, a very sort of humbling thing. And then the last question here, given the knowledge that you have about influenza's antigenic drift, what predictions might you have about how SARS-CoV-2 might behave similar?
Yeah, so it's clear that SARS-CoV-2 is mutating, and that that there is a fitness advantage to certain strains, that will. I don't think that for the short term it's going to impact things that much, because the mRNA vaccines are effective against the new strains, and if we have faster and more complete vaccine rollout, we may be in a situation where it won't matter. But all viruses mutate. SARS-CoV mutates much slower than flu, 10 times slower. So.
All right. Well, thank you so much. And thank you everyone for your wonderful questions. I think this concludes the scheduled portion for Grand Rounds, and everyone have a great Friday. Thank you, Dr. Chu, for being with us despite your symptoms of the second dose vaccine. I will acknowledge that you're not feeling great, but we're happy that Zoom allows you to be with us from home.
Thank you. Thank you. It was my pleasure.
Thank you, everyone.